Good afternoon. I'm Eben Rosenthal. I'm the medical director at the Stanford Cancer Center, and I'm going to talk to you a little bit about what we call the patient flow coordinator, which is also a scribe or human glue. So basically, this person is usually a high school diploma. They're often college graduates looking to go to medical school. The average length of employment is about 18 months. They work 8 hours a day. It's a pretty mixed male to female ratio. And this is the California, Palo Alto area cost and benefit. Cost of salary is probably somewhat higher than you would anticipate in other regions of the country. But we did a study and we looked at doctors pre-scribe and post-scribe about what their total visit duration was. So we looked at medical oncologists, and they had about a 20 to 30% reduction in their visit duration. If you look at the peers without scribes, so that's looking at a control group, but knowing differences in practice, we thought we'd present both numbers. So looking at the same physician, it's a 30% drop for medical oncologists, a 23% drop for surgeons. And interestingly, it was a pretty big difference between new patients and return patients, but overall a significant drop in the patient's time within the clinic. And here's just one surgical oncology provider. And one of the things that you can see, the new patient and return patient is substantially different, but what you can really notice is that the variation decreases. That is that the clinical variation, the time that a patient can expect to spend in clinic becomes much more consistent. And this had significant value to the patients and to the staff to be able to predict, because those outliers resulted in late clinics where staff were in the clinic after 5, which always results in significant burnout issues, both for the faculty as well as for nursing. And this is just a broad satisfaction scores where the physician felt in general that the scribe helped with most of the documentation and charting issues. Perhaps most importantly, this idea of a team was very important, and that training the patient flow coordinator was very important. Just as the high-functioning teams commented on, was the fact that if the relationship between the scribe and the physician is not efficient, then the entire process is not really improved, that the charting's not improved. And so in general, you can see patients were able to spend more time with their doctors, and overall the physician has routinely reported that their quality of life is improved. So in this respect, I think placing a well-trained EMR specialist in front of the computer and not the doctor was very effective. In addition to the cost deficit, I think the cost of the scribe, there's an additional patient in the room scribing, which in a medical oncology or surgical oncology discussion, when talking to the patient about risks and benefits or problems, I'm a head and neck surgeon, so there are some sensitive issues around eating and care that are somewhat not optimal in terms of how that discussion is led. And then we just asked physicians before and after the patient flow coordinator how much time they had to sign their notes a day, and you can see that fortunately it went down substantially amongst those physicians. So these are really the big takeaways. It works better for high volume practices, less for low volume practices, and we generally classified those as greater than 6 notes per session. Consistency is really critical in terms of that it has to be the same scribe. It's not a widget. They can't be replaced day to day. The preparation of the charts, understanding the workflow of the physician is really important. It decreases the physician time at the computer, and that allows them to have more face time. Perhaps one of the most interesting results of this study was not just the patient satisfaction, but the satisfaction of the scribe, who would inevitably go off to become a physician. So as part of their experience in the clinic, it was very positive for them, which we didn't quantitate in the study, but was noticeable. There's the added expense, and there's a high scribe turnover. And probably one of the most useful things that we did with the scribe program was include appended orders. So the physician going in and doing 4 clicks to get an order is probably one of the most painful things, and resulted in a lot of orders being placed at the end of the day. And the safety issue of a physician placing an order on a patient at the end of the day, the way that it is required, is not either efficient or safe. And so the scribe putting it in at the time was found to be much more effective. And obviously, I think, as we've heard today, is that the scribe is simply human glue for a very poor functioning EMR. We have Epic, and so the order process and so on is so dismal that we feel that this kind of thing is necessary at this point to improve burnout rates, and we found it to be very effective, although expensive. Thank you.